Hi, my name is Jenna Koss, and this is my presentation on hypertension. Clinical manifestations of the disease. Hypertension is a complex disorder defined as a constant elevation of systemic arterial blood pressure, which increases the risk for heart disease and stroke. Hypertension is the most common primary diagnosis in the United States and has a higher prevalence in African Americans and people with diabetes. Systolic blood pressure is the highest arterial blood pressure following ventricular contraction or systole. The diastolic blood pressure is the lowest arterial blood pressure that occurs during ventricular filling or dystole. The difference in the two readings is called pulse pressure and correlates with stroke volume and arterial elasticity. The body systems that directly impact blood pressure and contribute to hypertension are the cardiovascular system, vascular system, sympathetic nervous system, and renal system. In the cardiac system, both stroke volume, the volume of blood ejected in systole, and the heart rate will impact blood pressure. In the vascular system, the elasticity of the arteries and veins and the diameters of their walls affect blood pressure. The sympathetic nervous system causes dilation or constriction within the circulatory system through the release of norepinephrine. The renal system, in particular the renin-angiotensin-aldosterone system, RAS, directly impacts blood pressure. Elevated blood pressure can cause kidney disease and vice versa. Kidney disease can elevate blood pressure. Renin is secreted by the juxtaglomeralar cells into the blood in response to decreasing blood pressure. Renin splits angiotensin into a hormone angiotensin 1 in the liver, and then to angiotensin 2 by angiotensin converting enzyme, ACE, in the lungs. This is a vasoconstrictor, which will then elevate blood pressure. In addition, angiotensin 2 triggers the adrenal gland to release aldosterone hormone. Aldosterone helps to control blood pressure by increasing water and sodium retention in the kidneys. There are additional hormones that affect the blood pressure. Epinephrine is secreted from the adrenal medulla and will increase heart rate and cause vasoconstriction. Antidiuretic hormone is released by the pituitary gland and stimulates the kidneys to increase water and sodium retention and release potassium in the urine to increase the blood pressure. Lastly, the natriuretic peptide hormones induce diuresis, enhance renal blood flow and systemic vasodilation, and suppress aldosterone, which lowers blood pressure and controls electrolyte homeostasis. Hypertension can be broken down into primary hypertension, accounting for 95% of cases, secondary hypertension, accounting for 5% of cases, and complicated hypertension. Primary hypertension results from an interaction between genetics and epigenetic factors, but typically there's no cause identified. There are multiple genetic factors that play a role in the development of hypertension, including polymorphisms associated with renal sodium excretion, insulin and insulin sensitivity, activity of the sympathetic nervous system, RAS, and cell membrane sodium or calcium transport. The epigenetic factors are a combination of chronic environmental factors, diet, exercise, and smoking, merge with genetic expressions that consistently increase the cardiac output and/or peripheral resistance. Obesity increases the risk of a patient developing cardiovascular complications, as it is connected with inflammation, small arterial remodeling, endothelial dysfunction, and insulin resistance. Metabolic syndrome is a combination of hypertension, dyslipidemia, insulin resistance, and should be monitored in patients as they are high risk of developing type 2 diabetes and cardiovascular complications. Hypertension and type 2 diabetes are closely interlinked. People who have hypertension often exhibit insulin resistance and thus have an increased risk of developing type 2 diabetes. Primary hypertension risk factors include age, obesity, ethnicity, African Americans are at a higher risk, family history, lower education and socioeconomic status, tobacco use, psychosocial stressors, sleep apnea, and dietary factors. Increased intake of fat, sodium, and potassium and alcohol. Secondary hypertension encompasses underlying disease processes that increase the peripheral vascular resistance and cardiac output, where the blood pressure could return to normal if the cause was identified and removed before permanent damage occurs. Complicated hypertension is a chronic hypertension that leads to permanent damage causing hypertrophy and hyperplasia associated with fibrosis. Once significant damage occurs in the vascular remodeling, it creates reduced blood flow and dysfunction in the organs being perfused. The organs that are typically impacted include kidney, brain, heart, extremities, and eyes. Complicated hypertension also increases the risk of cardiovascular complications like ventricular hypertrophy, leading to congestive heart failure, angina pectoris, coronary artery disease, MI, or sudden death. In 2017, new parameters for classification of blood pressure were created. Stage 1 hypertension is systolic blood pressure of 130 to 139 and diastolic of 80 to 89. Stage 2 hypertension is a systolic pressure of over 140 and diastolic pressure of over 90 or higher. In hypertensive crisis, the systolic blood pressure is over 180 and diastolic blood pressure is over 120. Present illness. Per the case study, EW is an obese 40-year-old African American male who has had difficulty controlling his hypertension lately. He is visiting his primary care provider for a thorough physical examination and to renew a prescription to continue his blood pressure medication. He has a past medical history of hypertension and a family history of diabetes and hypertension. EW states he feels his overall health has been fair to good, but he does report a 20-pound weight gain during the past 12 months. The abnormal results of the physical examination include auscultation of the heart revealing normal S1 and S2 sound with a distinct S3 at the apex, indicating increased volume and increased pressure in the left ventricle, and underlying cardiovascular disease. In the lungs, mild basilar crackles were heard with auscultation, and patient reports some shortness of breath with activity, especially when climbing stairs, and the breathing difficulties are getting worse. This is indicating that the patient has an accumulation of fluid or mucus in his lungs, caused by pulmonary edema. He denies chest pain, shortness of breath at rest, headaches, nocturia, nosebleeds, and hemoptysis. The EKG showed increased QRS voltage, suggestive of left ventricular hypertrophy, LVH. The echo showed an ejection fraction of 46, indicating mildly reduced left ventricular ejection fraction and moderate LVH. The thickening of the left heart ventricle is often caused by uncontrolled hypertension. Fundoscopy revealed mild arterial narrowing with no ticking, hemorrhages, and exudate and papillary edema. This is indicating chronic microvascular damage from hypertension. Patient also has limited range of motion in his right knee and self-treats occasionally with over-the-counter extra-strength acetaminophen. Vitals include elevated blood pressure of 155/96, pulse of 73 and regular, respirations 15 and unlabored, temperature of 98.8, weight of 221, and height of 5'11". EW's fasting blood work is normal at 110. It is on the higher side of normal. An BMI of 31 with a 20-pound weight gain in the last year, and he has a family history of diabetes. All of these indicate a need for further blood work regarding his HbA1c level to determine if he could be developing insulin resistance. The HbA1c shows what the average blood pressure or blood glucose level has been over the past 2 to 3 months. Normal levels are below 5.7. Prediabetes is 5.7 to 6.4, and diabetes is 6.5 and above. EW urinalysis showed microalbuminuria present, indicating an early sign of impending renal dysfunction and increased risk for cardiovascular events. It will be important to get a GFR level to determine the extent of the renal dysfunction. Additional abnormal labs include elevated GGT at 119, elevated total cholesterol at 275, low HDL at 31, elevated LDL at 179, and elevated triglyceride at 290. Gamma glutamyl transferase GTT is an enzyme mainly found in the liver, and when elevated could mean liver damage or damage to the bile duct. The exact details regarding the amount of alcohol EW consumes is not clear, but he states he drinks several beers every evening to relax. The elevated GGT indicates a possible issue with the liver, but the patient would need further liver enzyme tests to determine the extent. EW's cholesterol levels are also off. His HDL is low, and his LDL and triglyceride are elevated, indicating hyperlipidemia. Hyperlipidemia is where low-density lipoprotein and triglycerides are elevated in the blood, increasing the risk for developing coronary artery disease, heart attack, or stroke. The risk factors for hyperlipidemia include smoking, alcohol, fatty foods, sedentary lifestyle, stress, family history, and obesity. His elevated blood pressure and hyperlipidemia is of concern as they put him at risk for a heart attack, stroke, or heart failure. EW has both genetic and environmental risk factors for hypertension. Both his father and mother have a history of hypertension, and his mother also has diabetes. His exact diet is unclear, but based on his BMI and his statement of salting almost everything he eats, sometimes even before tasting it, it can be assumed he has a high sodium intake. EW lives a sedentary lifestyle and only takes walks occasionally. He has a 10-year history of cigarette smoking, and drinks several beers every evening, which increases his risk of developing cardiovascular disease. Lifestyle modifications are an important part of first-line medication therapy and treatment for hypertension, and patients should be educated at any stage of hypertension with that. Allergies. The patient's allergies include penicillin, where he gets a rash. Past medical history. No known childhood past medical history at this time. Adult medical history includes hypertension, chronic sinus infections, pneumonia 6 years ago resolved with antibiotics, and one episode of major depressive illness 5 years ago caused by his wife's suicide. No known surgical history, no recent accidents and injuries or transfusions reported. Current medications include hydrochlorothiazide, 50 milligrams PO QD, pseudoephedrine hydrochloride, 60 milligrams PO Q6 PRN, and beclomethasone dipropionate, 1 spray in each nostril, Q6 PRN. EW is a 40-year-old African-American male who was obese with a BMI of 31. He smoked cigarettes for approximately 10 years but quit 11 years ago after he was diagnosed with hypertension. It is unclear how many cigarettes EW smoked per day, so more information would be needed to determine past history. EW states he drinks several beers every evening to relax. EW denies any diet. He denies he's ever dieted and does not pay particular attention to the sodium, fat, or carbohydrate content of the food he eats. He also admits to salting almost everything he eats, and sometimes even before tasting it. Illicit drug use and immunization history are unknown. He lives a sedentary lifestyle with no regular exercise program, but does take occasional walks. He appears to be his stated age and in no apparent distress. Family history. EW's father died at age 49 from an MI, and he had hypertension. His mother is alive and has been diagnosed with hypertension and diabetes. He has 3 siblings, 1 brother and 2 sisters. His brother died at age 20 from complications from CF, cystic fibrosis. His 2 younger sisters are alive and well. He has a 15-year-old son, but no medical history is known at this time. No other family history has been reported at this time. Personal history. EW is a widower. His wife died by suicide 15 years ago, and he lives alone. He has not been on speaking terms with his 15-year-old son for the past 4 years, and his son lives with a maternal aunt. He works as an air traffic controller at the local airport. His spiritual history has not been reported at this time. Pharmacologic therapy. Hypertension is diagnosed after at least 2, preferably 3, elevated measurements at different times. Once there is a diagnosis of hypertension, additional tests should be ordered to develop a baseline for therapeutic decision making, including EKG, urinalysis, blood glucose and hematocrit, serum protein, serum potassium, creatinine and GFR, serum calcium, lipid profile, C-reactive protein, and homocysteine. It is imperative that the target blood pressure and medication recommendations are individualized to the patient in order to prevent non-adherence to the treatment regimen. Typically, lifestyle modifications are the first line of choice for patients presenting with the risk of elevated blood pressure. Medications are started and combined with lifestyle modifications when the patient are presenting in stage 1 or stage 2. When selecting medication therapy for patients, it is imperative that the treatment of choice includes a consideration of cost, simple regimen to follow, and the fewest possible adverse reactions. Patients presenting in all stages of hypertension who are not able to achieve targeted blood pressure ranges, typically below 130/80, should be started on a medication. To assist in achieving therapeutic ranges, the following should be set: a patient-centered therapeutic range, aggressive treatment for hypertension, yet limit adverse reactions. Titrate blood medications no more than every 4 to 6 weeks. Start low and increase. Single medication treatment is often not enough to get to the targeted goal. An additional medication may be required. With older patients, it is imperative to go slow with treatment and titrate to the target of 150/90. If after 1 or 2 months you have not reached the targeted goal, it is time to start thinking about the next dose level or addition of a second drug. First line medications include angiotensin converting enzyme inhibitors, ACEI, angiotensin II receptor blockers, ARB, or thiazide, and in African Americans, calcium channel blockers. ACI or ARBs are considered first choice in patients with diabetes, and calcium channel blockers are first choice in African Americans due to the lower renin response in this ethnic group. Beta blockers are not recommended as a first-line medication. Instead, used as a second-line medication or add-on drug due to the multiple adverse effects and weaker anti-hypertensive properties. Stage 2 hypertension is most often requires a two-drug combination, usually with a thiazide type medication combined with an ACEI, ARB, beta blocker, or a calcium channel blocker. EW is an African American male presenting with complicated stage 2 hypertension with hyperlipidemia, moderate LVH, and possible liver and renal dysfunction/damage. To determine a baseline for his liver and renal function, it will be important that EW gets GFR and liver enzymes blood work. He is currently taking hydrochlorothiazide 50 milligrams PO QD for his hypertension. Pseudoephedrine hydrochloride, 60 milligrams PO Q6 PRN. And beclomethasone dipropionate, 1 spray in each nostril, Q6 PRN for his chronic sinus infections. His blood pressure is not in the targeted range, and he is not currently on any medications for hyperlipidemia. I would take EW off his current hydrochlorothiazide medication and prescribe an ACEI, lisinopril, combined with hydrochlorothiazide medication. Cost of antihypertensive medication should always be considered when selecting one. Generic and combination drugs can help reduce cost. EW has moderate LVH and ejection fraction of 46. ACI have demonstrated most effective in reducing left ventricular mass and wall thickness. ACI and diuretics in low doses have been shown to help renal function, lower effects on glucose metabolism, and lipid profiles. Lisinopril has minimal hepatic metabolism. However, impaired renal function decreases elimination of lisinopril. EW also is presenting with pulmonary edema, indicating that he could be in early stages of developing heart failure. In patients with heart failure, calcium channel blockers are not typically recommended, and ACI are commonly prescribed due to their ability to decrease both arterial and venous resistance. Baseline blood pressure and pulse should be taken before initiating and before each dose change. Initiating the medication and before each dose change. The patient should be seen within 4 to 6 weeks after initiating a new drug to evaluate its effectiveness. Pharmacotherapeutics for lisinopril combined with hydrochlorothiazide include precautions, contraindications, adverse reactions, and health teaching. The precautions include hepatic impairment, hypovolemic and hyponatremic states, and hyperkalemia. Serum protein levels should be checked before initiating therapy and within 1 week to note trends. 3 important contraindications include bilateral renal artery stenosis, angioedema, and pregnancy. Adverse reactions are usually transient, mild, and more common in longer-acting agents. Some adverse reactions include cough, usually occurs within the first week of therapy, electrolyte disturbances, gout, hematologic effects, hypersensitivity, hypotension, syncope, ocular events, and photosensitivity. Patient is currently taking beclomethasone dipropionate nasal spray and pseudoephedrine hydrochloride. There is no interaction and should not impact the patient taking lisinopril hydrochlorothiazide. Education should be focused on administration, adverse reactions, and how to respond to them, and combined with lifestyle education. The medication should be taken as prescribed, and any missed doses should be taken as soon as remembered, unless it is close to the next dose. Do not double dose if missed. Over-the-counter medication should be consulted with a provider First, as they may counteract the effects, and also salt substitutes should be avoided as they often contain potassium. Possible orthostasis occurs within 1 hour of administration when starting the medication and any dose change. Hypotension is an adverse reaction and may cause falls, and the patient should be educated about changing position slowly. The patient also needs to be educated on the importance of adequate hydration to prevent this and maintain appropriate GFR. The patient should report any swelling in the feet and ankles and if there is decreased urine output. It will be important to also educate the patient on angioedema and cough, as African Americans are 3 to 4 times at higher risk of developing them. Flushing of the face, hoarseness, swelling of the eyes, lips, or tongue, and breathing difficulty breathing are all signs of angioedema. If the patient develops angioedema, it usually occurs within the first dose or within the first month. The medication must be discontinued and no other drug can be used in this class. ACIs are often discontinued because patients develop dry, heckling cough that occurs within the first week of therapy. Patients should be educated on the cough and only discontinued if it interferes with their life. The lifestyle education should be focused on the importance of weight loss. 5 to 10 pounds can significantly decrease blood pressure. A healthy, low cholesterol diet, high in fruit, vegetables, and low-fat dairy. Reduction of sodium. Limit or eliminate completely alcohol intake. And increase aerobic physical activity, which are all crucial to preventing further complications. EW has an elevated total cholesterol of 275, low HDL of 31, an elevated LDL of 179, an elevated triglyceride of 290. Would you treat him for hyperlipidemia? If you would not treat him, why? If yes, what medication would you prescribe? Any drug interaction with his current medication regimen? Second question. EW had one episode of major depressive illness 5 years ago caused by wife's suicide. He lives alone, drinks alcohol every night, and has a poor diet and is not on speaking terms with his son. He is currently not on any depression medications, but has risk factors for depression. After discussion with the patient, you decided to prescribe a medication for depression. What medication would you select? Any drug interaction with his current medication regimen? Last question. After 1 week, EW developed a cough that interfered with his life. He came back to the office to discuss another medication. What medication would you select and why? And here are my references. Thank you.